Hello, and welcome to the Engaging Heart Failure Patients in Their Care conference call. My name is Michelle, and I will be your operator for today's conference. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session, and during the question-and-answer session, if you have a question, please press star, then 1 on your touch-tone phone. I will now turn the call over to Ms. Janelle Shearer. Ma'am, you may begin.
Thank you, Michelle. Hello, everybody. This is Janelle Shearer. I'm with Stratus Health, one of the organizations that is part of the Lake Superior Quality Innovation Network, or Lake Superior QUIN. Lake Superior QUIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. This webinar is presented in a collaborative effort between the Lake Superior QUIN and Great Plains QUIN, which includes the states of North Dakota, South Dakota, Nebraska, and Kansas. So welcome everybody from all of our states. We are all working with organizations in our states in a community-based approach to reduce the 30-day hospital readmission rate by bringing organizations together in communities to improve care transitions as people move across the continuum of care. Since heart failure is a top readmission diagnosis for patients in all of our states, we are focusing on a webinar series on heart failure. This is webinar 5 of the series of 6. I would like to welcome you to this educational session entitled Engaging Heart Failure Patients in Your Care. Before I introduce the speakers, I'll also mention all lines are muted during the webinar. However, after the presentation, we will have a time for Q&A, so just jot down any questions that you might have. We will also be using the chat feature, which is on the right side of your screen. Jenna Kornberg from Stratus Health will be watching the chat, and so feel free to put your questions in as you have them. Because Metastar is providing continuing education credit for this presentation, we need to inform you that no commercial support or sponsorship has been received for this learning activity. Leah Hochstein has disclosed an affiliation with ComfyCare Wear as a co-owner. No other relevant relationships have been reported. For CE credits or certificate of attendance, you must attend the entire session and complete an online evaluation that you will receive at the end of this session. We encourage everyone to complete the evaluation to provide feedback of the session. Now, I'd like to introduce our speakers, Leah, Lori, and Len. Leah Hochstein is a nurse practitioner in the Essentia Health Elder Care Geriatrics Department in Detroit Lakes, Minnesota. She has experience in long-term care and hospice as an RN and as a nurse practitioner in both nephrology and geriatrics. Leah will start the presentation today. Lori Olson is an RN and Director of Nursing at Sunnyside Care Center in Lake Park, Minnesota. Lori has cared for the elderly for nearly 40 years and has been DON at the Sunnyside Care Center for the past 10 years. Leah Schramm is a daughter and patient advocate for her father. She will be sharing her dad's story today. Len is also an elementary education teacher. Thank you, ladies, for presenting today. Leah, I will now turn it over to you.
Thank you. Our objectives for today, we're going to be discussing the importance of engaging heart failure patients in their care. We'll be describing and discussing some techniques and strategies to do so. And also, we're going to be talking with Lynn, who is the family of a patient, and we're going to talk about how we were able to manage heart failure symptoms as we were actively participating or he was actively participating in his care. So as we begin, we all understand that we're here because of heart failure and the high readmission rates. I just wanted to touch briefly on the high prevalence of heart failure. It's not just in our country, but also worldwide. There are 26 million people worldwide with this diagnosis, and the treatment costs are quite expensive. Currently, they're greater than $30 billion, and they're expected to rise to over $69 billion by the year 2030. There's a high readmission rate to the hospital, and this is due to disease exacerbation, which has been linked to poor self-care, which we'll be discussing further in later slides. We know that heart failure greatly decreases quality of life, reduces physical function, executive functioning, including memory, and the symptoms of CHF commonly include weakness, fatigue, memory loss, anxiety, headaches, and insomnia, not to mention the exertional dyspnea, orthopnea, and edema. In many cases, by modifying behavior and strengthening the adherence to drug therapy, as well as using devices to improve outcomes, have shown to significantly decrease the readmissions of CHF, which is a major health problem. The goals for CHF treatment are to prolong life and improve the quality of life. Multiple studies have identified that self-management is a key factor for successful heart failure management. What I mean by this is heart failure self-care is comprised of physical and cognitive activities and behaviors that can influence and the maintenance of the disease process, improving the patient's overall well-being. In summary, self-management equals successful management. Examples of self-management include medication and diet adherence, exercise, and preservation of the spiritual and emotional health, which we know impacts the physical health as well. There was a study I read while preparing this talk that was actually completed in Saudi Arabia, and the researchers were looking at the rehospitalization rates of elderly persons with CHF. What they found is that over half of the readmissions, actually 55.5% of those readmissions, were considered preventable. And the most common preventable cause was due to poor medication compliance. I know there's many reasons for poor medication compliance, but how do we know what those reasons are unless we engage with our patients and know the why for what is happening? The researchers further identified that multidisciplinary measures, including patient education and home-based care, were interventions that improved the readmission rate. Before I talk further about the techniques and strategies to engage with our patients, I first would like to talk about barriers. As I go forth with discussing the techniques and strategies, there will be a barrier for each of the things that I discuss. But my take-home point here is that each plan of care must be personalized. And as we're personalizing our plans of care for the patient, it's important to identify goals of treatment, as well as their perceptions and beliefs and values that will impact the goals of treatment, as well as recognizing the comorbid conditions. For example, if a patient has a cognitive impairment, this is certainly going to be a barrier to their self-management and their ability to care for themselves and manage their disease process. The take-home point, in summary, is that this is certainly an opportunity for advanced care planning and discussing the goals of care in relation to the disease process. As I was completing the literature review in preparation for this talk, I recognized that there were 4 themes that were common in the literature. We'll call these the domains of self-management as we go forward. These include education and teaching, behavioral modification, psychosocial, as well as collaborative care. Educational strategies to engage patients in their CHF care must go beyond the discharge teaching. Oftentimes, patients are diagnosed while in the inpatient setting. They're acutely ill, and they're not in a situation where they can properly understand or absorb the teaching that we're giving them. Be creative. Go to your outpatient clinics and your home health services and see how you can implement educational strategies to improve the patient's self-care. A couple of studies I'd like to touch on that I found in the literature included one by Boyd et al., and they found that using an educational DVD with a written manual reduced the 1-year readmission rate by 30%. This was a self-paced education program that the patients were able to do in the comfort of their own home. Another study, which was completed by Buck and al., they use a technology system, something like a phone app, that helps the patients identify appropriate goals and ways to reach those goals. They found that these apps improved satisfaction with their life, as well as facilitated information sharing with others, which is more like support and support groups, but in a technology style. Spaulding and all completed a literature review which looked at patients' perceptions of self-care, and they found that patients were often able to recall what the healthcare providers told them about self-care, but were not able to integrate this into their daily life. So this is important to understand because we need to show the patients not just what to do, but how to do it. The fourth study in relation to the education and teaching was completed by Curie and al., and they looked at the importance of interactions between patients and healthcare professionals for their heart failure self-care. They found that interactions between clinicians and the patients substantially improves the capacity of a person's ability to perform their heart failure self-care. And the way that the healthcare professionals interacted with the patients strongly influenced the patient's understanding about their condition and their self-care behaviors. So these last two studies touch more on how we should be providing the education and the relationship we should have with our patients to engage in their self-care. Behavioral strategies to engage patients in their heart failure care. There's two techniques discussed on this slide. A study completed by Jing and al. Did a literature review which reviewed over 29 studies totaling close to 4,000 participants, and they looked at the effects of psychological interventions, including motivational interviewing and cognitive behavioral therapy. They found that both of these strategies were effective in improving the self-care among heart failure patients, but they did find that as more time passed, the less effective the intervention was. This is important to understand that the continuing of the intervention is needed to maintain the effectiveness. Motivational interviewing is a conversation about change. It also identifies the motivation and commitment for the person to complete the change. And it's collaborative. It's a dialogue back and forth between the patient and the facilitator of the motivational interviewing versus a teacher versus student model. The cognitive behavioral therapy is more goal-oriented at problem-solving and used to change patterns of thinking or behavior while helping the patient identify the problem-solving techniques to attain those goals. Psychosocial strategies to engage patients in their heart failure care include support and social support. This can be done in a variety of ways, through group or one-on-one with the family, provider, nursing, interdisciplinary team. Dravin and all completed a study looking at the intervention of social support and problem solving and using them together. They had three groups. The control group was the usual self-care, heart failure management intervention, where the patient would come to the clinic and see their provider on a routine basis. The other two groups included involvement with a nurse practitioner. The nurse practitioner would do phone calls with the patient, and then in the other group they did home visits. What they found is that the group that had the nurse practitioner home visits, where discussion was held and teaching was done in regards to problem-solving techniques, had the best success for improving their self-care maintenance, which involved the treatment adherence and monitoring of the disease symptoms, as well as overall self-management or response to symptoms, and their confidence in their self-care, which is defined as their perceived ability to carry out their self-care activities. Close behind was the group that used the phone calls, and both of these groups had a statistical difference than the control group. Also, as we're working through the problem solving with these patients, we're able to identify abilities and resources. And by abilities, this also brings forth the concerns for cognitive impairment, which would impair their ability to self-care. collaborative care, interdisciplinary surveillance. The way I explain this to my patients is that we are all on the team, but the patients and I are co-captains, and we must decide how to use the other teammates to play this game or to manage this disease. The other team members may include primary care, home health staff, facility staff, cardiology, nephrology, and the patient's family. They are all players when it comes to the collaborative care. I reviewed a study that was done by Hua et al., and it was completed looking at a collaborative care model, and what this model consisted of was using a primary nurse to provide education and teaching, and they used a booklet as well as a videotape which introduced the disease process as well as medications and interventions as well as potential adverse reactions to the drugs commonly used for CHF. Then the primary nurse supervised the patients and the caregivers in managing their symptoms and adjusting to their new lifestyle. They also taught about daily weight management of blood pressures, heart rate management, and diet, including salt and water intake. They also discussed exercise and sleeping. The caregivers then completed follow-up phone calls with the primary nurse, and they were able to offer feedback as far as the patient's adherence to the education and teaching that was provided from the primary nurse. The scores in the self-care maintenance, management, and confidence were all significantly higher than the control group. What I also found interesting in this study is that this collaborative care model also showed to improve quality of life scores as well as lower the BNP. Another intervention that is along the lines of collaborative care is the use of telemonitoring. We're going to talk about how this has been beneficial in the later discussion with the patient's family. But a study completed by Inglis et al. Looked at the intervention of telemonitoring and how it reduced the risk of all-cause mortality and heart failure-related hospitalization. And they found that there were significant improvements in health-related quality of life, as well as heart failure knowledge and self-care behaviors. And they also found that the participants had a significant satisfaction with this intervention. Overall, with collaborative care, we must communicate. Providers should be communicating with the patient, with the family, as well as with the other disciplines and who are part of the healthcare team. An example from my own practice is that I will send notes or CC my notes in regards to my patients to their specialist, for example, their cardiologist or their nephrologist or to the CHF clinic. As I am able to do health calls and things, I'm able to be the eyes and ears for those specialists as well. The pictures here are of myself with my patient, Harry Fugley, and then on the right is myself, Harry, and his daughter, Lynn. I'm now going to turn the presentation over to Lori and Lynn.
Thank you, Leah. This is Lori, and I'm going to ask a few questions of Lynn so she can explain what they've been doing with her dad. And tell us a bit about your father, including a little personal and some about his health issues.
Well, my dad, Harry Fugley, will be 93 years old in December. He grew up in Newland, Minnesota, which is a small town in northwestern Minnesota. Met my mom in Lake Park, and they lived there for almost 70 years. Mom passed away last February, just 2 months shy of their 70th anniversary. Dad started and was the manager of the Lake Park Scenics for over 40 years. He loves to fish, and they've had cabins on area lakes since the 1950s. and they spent their summers there. He also enjoys Minnesota sports, baseball, football, and hockey, and he was the #1 fan of his grandson's hockey and baseball games. Mom had many health issues the last 5 to 10 years of her life, and he was her caregiver until he developed congestive heart failure and AFib in March of 2016. I want to share a little bit of history of Dad's health. In 1993, he went through treatment for prostate cancer, having it removed and radiation. In 2003, he had a quadruple bypass surgery, and he didn't have any problems until March 2016 when he was diagnosed with AFib and congestive heart failure. He had a pacemaker put in and was admitted to transitional care for physical therapy. He was discharged in May, just in time to spend the summer at the cabin. And Mom was in a nursing home at that time. But it was a tough summer for him. He had a lot of trouble controlling the fluid in his body. He was dizzy, weak, had to be in air conditioning all the time. He was winded when he walked, often needed a wheelchair, and legs were swelling, and someone had to be with him all the time. He also had panic attacks when he had trouble breathing. We had a different doctor at that time. We didn't have Leah at that time. And it was just kind of a guessing game on the water pills. So in August, we finally saw a cardiologist, and he put Dad on a daily water pill. In September, he ended up in the hospital again with fluid overload and went to transitional care for a couple weeks and then assisted living facility. And at that time, we switched to Leah as his medical provider. She did the home visits, and she's there. We arranged weekly visits from a home health nurse, and we set up the telemonitor heart scale, which is monitored by cardiac rehab. And while we were getting all of these things set up, Dad was admitted into the hospital again, and they removed 15 to 20 pounds of fluid while he was in the hospital, and it's been off ever since. And shortly after that hospitalization, we met with the CHF educator, and she gave him a plan, how much fluid he should have, what he should eat, what he shouldn't eat, stay off the salt, and the importance of the daily weights at the same time, wearing the same clothes. And he is so disciplined with this plan, and it is really working. His goal is to stay within 189 to 191 pounds, and he has a routine every day to help with this. He weighs himself every day at 5:30 a.m. After breakfast, he takes his water pill. He puts his feet up for 2 to 3 hours. He participates in the exercises at the facility, and he follows the diet. It is working. And this summer he was able to be outside. He enjoyed daily trips to the cabin, mowing the yard. His dizziness is gone. He's stronger. There aren't any panic attacks. He's able to walk long distances with his walker without getting winded. And he's very proud of how he's doing. We did have a couple of situations this summer when the humidity was high and it was bothering him, but he knew what to do and he was able to control it. We're also dealing with a little bit of kidney failure that we're watching. But he's, like I said, he's very proud of the progress that he has made.
What impact has this program had on you as a daughter then?
Well, I'm fortunate that I was able to retire from teaching 5 years ago to help take care of both my mom and my dad. So doctor appointments and being an advocate and helping him has become my job. And I've learned a lot about the medical field, but I'm very glad that I'm able to do this. I have other siblings who are helping too, but I'm the sibling who deals with the medical issues.
What recommendations would you have for other family members or healthcare workers?
My first recommendation is to become educated about the illness, both family members and the patient. Learn how to manage the illness, look for problems, and know what to do. The second would be the communication between you, the patient, and the medical people working with your parent. That's so important. You can catch it before it gets too bad. And the third would be to get involved and be your parent's advocate. They don't always hear or understand the doctor or understand their illness, but make sure they do. I take notes on my iPhone at every doctor appointment and go over my notes with Dad after the appointment to make sure he understands what the doctor said. Also help your dad or your parent tell the doctors about their symptoms and their problems.
what you think made the difference in how he was able to manage his health.
Well, being educated on this disease and given a plan what to eat, that was a big thing, and he has a good routine going. The telemonitor heart scale, and I'm just going to briefly tell you what he does with that. He turns it on every morning, and they ask him 10 questions like, are your legs swollen, are you having trouble breathing after walking, and he answers those. And then he weighs himself every day, and that goes up to the cardiac rehab. And they will call him if there's a problem. But he can monitor his weight. He watches it, and if he gets above his weight, then he knows what to do. Cuts down on his salt or watches what he eats, and he puts his feet up. Also, the daily water pill has helped, and following a heart-healthy diet, and he eats his meals at the assistant living, and that has helped. The weekly visits by the home health nurse and the home visits from Leah, and the communication that we have going with nurse, the CHF educator, and the cardiac rehab. That's a big thing.
Very good.
I think that's the other question, too. You want to do the dance? I did do those.
Okay, good. Lynn asked her father a series of questions, and his answers are as follows. What was it like for you to find out you had a chronic condition such as heart failure?
He said, I was getting old and worn out. I didn't think I was going to die. I was just going to get it fixed and keep trying.
How did it affect your life?
It restricted on a lot of stuff. I had to stay clear from work. It restricted me from doing everything that I like to do. I had to stay put.
What made the difference in managing your health?
Well, my diet and water intake made a big difference, being careful what I do and eat. I weigh myself on that fancy scale every day, and that has helped me. My weekly visits from the nurse and the doctor's home visits have helped. I learned to live with it. I found out what works and doesn't work, and I follow the routine.
How are you doing now?
The nurses and the doctors tell me I'm doing good.
What recommendations do you have for other people with a chronic condition such as heart failure?
Find out what you should do and shouldn't do, and do it.
Thank you, Lynn. I have a few questions for Leah now. What approach did you take in helping him manage his chronic condition?
I was quite fortunate because when I started to do home visits with Harry, he had that safety net already developed around him with the CHF clinic, a supportive family, the home health nursing, the facility staff. So as I mentioned earlier, I walked in and Harry and I had a talk, and I said, all right, you and I are in this together, and we're going to use the resources that we have, and we're going to continue to manage these symptoms and help you live the best quality of life we can.
What was it that turned the light bulb on for you and for him?
I was able to sense his motivation from the beginning when I first met him. And he was, again, quite proud of his, quote, fancy scale. In fact, I've had students follow me, and he likes to show the scale to the students and show them what it is and tell them how he's been successful with it. So I guess the light bulb turned on for him and I pretty much from the beginning. He was motivated. I was ready to help direct the care and link him up with resources and be his advocate from a medical perspective.
What recommendations would you make for other healthcare workers in helping people manage their chronic conditions?
There needs to be discussion and review of what the patient understands. A statement I like to use is simply, tell me what you understand about blank. In this example, CHF. It's interesting, a lot of patients don't have the appropriate understanding of their disease process, and from there it will guide your teaching. Also assessing their motivation for learning and how they learn best. For some people it is just talking in the clinic. I've been known to draw pictures and scribble all over papers or on the back side of envelopes during home visits to explain a process, or disease process rather. And then also reviewing what are their goals. For Harry, his goals were to maintain quality of life, to be able to go to the lake and continue to mow the lawn and go fishing and fry fish in the summer. And for others, their goals are different, and so tailoring their plan of care to what's important to the patient, and always keeping what are their values and beliefs on the front side of your conversations as well, as that will impact how they will use interventions and manage their care.
Thank you, Leah. That is our presentation, Janelle.
All right. Well, thank you so much to all three of you, and also say thanks to your dad, Lynn, for us. I would like to open it now for questions. So, Michelle, if you would give directions, please.
Yes, ma'am. We'll now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, you may press the pound sign or the hash key. There will be a delay before the first question is announced, but if you're using a speakerphone, you may need to pick up on your handset first before pressing the numbers. Once again, if you have a question, press star, then 1 on your touch-tone phone. Ma'am, we're standing by for questions.
Okay, so while we're waiting for any questions on the line, we're watching the chat, and we have one here. So Jenna is monitoring that for us.
Yeah, we have a question from Emily. She asks, what would you do for the patients who are not necessarily motivated?
That's a good question. So, again, going back to the techniques of the cognitive behavioral therapy or the motivational interviewing, and trying to work with that patient, I would also want to identify what are the barriers to the motivation. Are there underlying things that need to be discussed before we can reach a motivated state? For example, depression, situational depression, anxiety. Patients are quite overwhelmed when they have a new diagnosis, and trying to sort through some of those things to really get down to why aren't they motivated.
This is Janelle. I have a question for you, Lynn, and you may have answered it. But what do you think it was that really motivated your dad? So many people have heart failure, and they, for some reason, they just can't, follow the diet regimen, or they struggle with the pills, and especially when you think of the water pills or the diuretics. What do you think it was that really motivated him?
Well, he's always been a goal-orientated guy. So I think it's almost kind of like a game for him to make sure he keeps his weight between 189 and 191. That's just kind of his personality. And I think he just loves life. He wants to be able, like Leah said, to be able to fish and go out to the cabin and be with family. And that's just the way he is.
Yeah, so then it sounds like since Leah was able to find out what was important to him, which was the fishing and his activities, he made the connection that if I follow my medical regimen, I will be able to do that. Is that right?
Yeah.
Great.
And I think another thing that helps him is he knows he's not alone. He has a team of people that will help him. And, we feel that we can call Leah, his home health nurse, cardiac rehab, anytime, and they'll be there to help us. And that has really been a motivation for him, too.
Great. Thank you. Oh, I see we have some more in the chat.
Yeah. Another question, can you share the names again of the sources for the DVDs and apps?
Yeah, I'm digging here. Just digging. There is a list of my resources on the last page, too. There, I'll go to that. Right, so the DVD and app was the first reference there, Boyd. Oh no, yeah. So the DVDs was Boyd, and then Buck was the one about the technology system. Oh, I'm sorry, I don't see Boyd on, or Buck on there.
Yeah, we see Boyd. That's the first one.
I can certainly.
How about the fifth one?
It's Buck, B-U-C-K.
That's from the bottom, isn't it? That's fourth from the bottom.
Oh.
Okay.
Yep, sorry. It's under Lloyd. L-L-O-Y-D. The fourth from the bottom.
Do you happen to know the name of the app if people wanted to download on their iPhone?
There wasn't a name.
Okay.
They just called it a technology system in the article.
Okay, thanks.
Yep.
We have another question. Says managing a chronic condition long-term can be exhausting. How do you re-engage who is initially motivated but loses motivation over time?
Oh, that's a really good question. Yeah, really looking at what else is going on. These patients often they get defined as CHF, and we really need to look at who are they beyond their CHF and what else is happening in their health status and in their personal lives and their social circle that could impact their emotional health. That would then lead to maybe lack of motivation. I agree that the chronic disease management is exhausting. It's a daily task for these people, but also if they're well supported, as the research shows us that a well supported patient is successful. So do they have the appropriate support that they need, or what is missing for that patient?
Great. We have a couple of comments. First one is to find out what motivates them first. Is it being able to play with their grandchildren, walk a city block with minimal struggle, attend church, or what? What do they want to see improvement in their life? And then connect that up with the control of heart failure and see how it will help meet that life goal. And another comment is, my exposure to diet in the assisted living setting and skilled nursing facilities has been discouraging. I see little in the way of low-sodium food preparation. I've been told that these facilities are required to only offer low-sodium foods. They want the residents to enjoy their food.
Any comments on that from anybody?
I'm going to give that to Lori.
I do have a comment because I too have that opinion. And because when I would taste the food, it tasted salty to me. And so I pushed until dietary counted the sodium content for a day, and they were correct. They were within the guidelines. I'm not really sure why certain things taste more salty than others, but they are within the guidelines. And nursing homes today allow a lot of freedom. So if a resident wants a bag of potato chips and they are on the snack tray, that's what they eat, even though we do our best to discourage that. But yes, I could see where that opinion came from.
Thank you.
And then to tag on to that, in the assisted living world, there's even more freedom. Some assisted livings, the patients may only receive one prepared meal a day, and the other meals is on their own.
So it really does depend on what a person chooses to eat then and to have an understanding of it.
We have another question for Lynn. How did your dad's panic disorder get resolved? Or was it just anxiety from not being able to breathe and it was a teaching moment?
It was anxiety for not being able to breathe, but he is on an anxiety medicine, very low dose, and that helped. That summer that he was having a tough time, we did have oxygen, so he was put on oxygen when he would have a panic attack for a short amount of time, and then we would go to the doctor and try and get it fixed. So that's how we dealt with that.
Does he chronically use oxygen now?
No.
Not at night?
No, nothing.
He doesn't even have it in his apartment.
I got one hidden.
Oh, do you?
Yeah. No, he doesn't need oxygen. He hasn't been to the hospital in over a year. So it's working for him.
Yeah, that's amazing. Thanks for sharing this story. Michelle, I'm going to check in with you to see if you have anybody in queue on the phone line.
Yes, we do have one in the queue at this time. Tanya, your line is open. Go ahead and ask your question, ma'am.
Yep, I was the one actually that was wondering about the panic disorder. So that was kind of answered, because I've often wondered about that with that, how anxiety and the heart and the breathing and all of that kind of plays in with each other, and them not being able to breathe, and especially if they have extra weight on them and stuff like that. So that always is interesting to me to figure out how to explain that to that patient that is feeling like that. It's a real true feeling to them and scary feeling that they can't breathe, and it does lead to panic and things like that, and so so that was I'm glad she answered like she did, and that's all I was.
Dad also would sit in front of the air conditioner or the fan too to get himself calmed down too.
Yeah, I've heard of people doing that as well. My grandmother used to do that too. So it's interesting that they do try and find their own way of that air movement. So that's interesting that you would say that. Thank you.
Okay, there are no other questions in the queue at this time, ma'am.
All right, our next question in chat, any recommendations for coordinating large care teams such as home health, cardiac rehab, telehealth, etc., without overlapping services or confusing the patient?
Again, that goes back to the primary provider really needs to step up and be the team leader. And what I do with my patients is, so they go to, say, nephrology, and they come back with recommendations, and we look at the big picture. Those are recommendations. Are they applicable to the current situation when we look at the big picture? And also, I also use our Epic inbox to message the other providers and gain insight. And as far as overlapping services, I really don't see that in my practice. I have identified our roles quite well, I think. So I don't really know that I have a good comment for that piece.
Our next question, to clarify about identifying psychosocial behaviors, do you formally screen patients or discuss it only if the topic is brought up?
My patients, I think what you're referring to is depression and anxiety is my assumption. I screen my patients at least once a year. I use either a GAD-7 for anxiety or a PHQ-9, and then I also will use a geriatric depression screen, depending on the patient. And then if they're on a medication for one of those diagnoses, then I will screen them more often. If they're in a facility, of course, they're being screened with the MDS or with the quarterly reviews on the assisted living side. But in my clinic practice, that's my general assessment period.
Another question, any additional recommendations with completing education in a short-term rehab unit and helping a patient to be successful once discharged home independently or with family?
That's a great question. So I also round and see patients on the transitional care unit. And it's a prime opportunity for education. You have all the team players right there. You've got therapies, you have nursing staff, you are having discharge planning and care conferences with the family. So trying to provide the education while they're there, and I would hope that they're motivated. If they're on a transitional care unit, they have a lot of rehab to be done to help before they go home. Some ideas would maybe be, and this of course would be if finances weren't an issue and staffing weren't an issue, but if we could have a CHF nurse educator on our transitional care units, wouldn't that be fantastic? Or linking up with your palliative care programs. CHF is an incurable disease, right? So palliation means symptom management. That's a lot of what we're doing. Utilizing your palliative care teams, for example, in our area, we have an outpatient palliative care program. That nurse would then be knowledgeable about teaching about disease process, helping recognize symptoms, what would be appropriate interventions based on the patient's goals and wishes once again.
Great, thank you. We'll check in one more time with Michelle if anybody has a question on the phone line.
No, ma'am, I have no questions in the queue.
All right. Looks like we've covered all the chat questions. And so I just want to say a huge thank you to all three of you, Leah, for your work with patients in the different settings, and Lori for finding this great story for us, and then Lynn for you for sharing your dad's story. And please tell your dad thank you for being willing to have this story shared as well. So this concludes our educational session for today. And again, thanks to the speakers for speaking with us today. The next webinar in this heart series is on caring for heart failure patients at end of life. The date is still up in the air, but will either be the end of November or probably fairly early December. We'll get that. You'll hear from your QIO as soon as we know. So before you close out today, please complete the survey that will pop up. We will also put the link to the survey in the chat box. We appreciate your feedback on today's session. Once you've completed the evaluation, you will receive a certificate of completion via email. Please make sure that everyone on your team that wants a certificate also completes the evaluation. This session was recorded and will be available on the Lake Superior Quinn and Great Plains Quinn websites in about 2 weeks. Thank you, everybody, for participating, and have a great afternoon.
Thanks. Bye.
Thanks so much.
Ladies and gentlemen, this concludes today's conference. You may disconnect your phone line.